Hello, I'm Seth Bilazarian, a clinical and interventional cardiologist at Pentucket Medical Associates in Massachusetts. And this editorial program on electronic medical records in cardiology practice is being brought to you from the American College of Cardiology. And I have a group of panelists with me who are electronic medical records adopters and some leaders in the ACC's program for improving quality in electronic medical record adoption. And I'm excited to have a conversation here with them about issues that they've faced in implementation, about issues they've faced currently with ongoing use issues such as adopting standards, health information exchanges, and of course the big issue that's facing many practices now is meaningful use. So I'd like to introduce the panelists, and to my right here is Dr. Vincent Bufalino from Chicago. He's in a single specialty group and using electronic medical records for many years, and I'll ask each of you to tell us a little bit more about your experience. Dr. Ronald Karlsberg is from California, also been using electronic medical records for many years, and Dr. Jay Alexander from Chicago also, who has the opportunity to tell us about multiple electronic medical records and multiple adoptions. So I'll just begin by saying that we're hoping that this will be a very practical program for those who have not yet begun using electronic medical records or who have begun in our early stage or are more advanced and may want to hear about the initiatives that American College of Cardiology has or other government initiatives. But also we hope that this will be a practical issue with regard to some very fundamental issues like cost and other kinds of issues that come up in terms of adopting it into our practices. I will say briefly for the purpose for those who may not yet be using electronic medical records that I want to define electronic medical record. And an electronic medical record is not a digitized paper record. It's not a group of Word documents that exist on a computer and that you've just sort of shifted over. We're really talking about an electronic medical records that are being defined largely by the government as structured data with data in certain fields for both medicines and problems, allergies. The government is specifying specifically early that we actually structure data for smoking use. So there's a variety of very critical things that electronic medical records do, and it's not a digitized paper record. So for the purposes of that, that's really what I wanted to take on. And then I'll just begin by asking for some general experiences about electronic medical records. I'll start on the end and ask Jay to tell us about your experience in your group and how you've used it.
Well, we're a 12-person cardiology group in the north suburbs of Chicago, and I think we've now have the distinction of having had implementing our third electronic medical record in probably a decade. I think it's been a little short of a decade that we've gone through 3 electronic medical records, and for various reasons. So it's been an interesting ride for us, and we've had a number of obviously problems in implementation over time and choosing the wrong electronic medical record, and now with the advent of or the movement towards integration of practices into hospital systems, now the confrontation of a third medical record, which is basically the health system's medical record. So it's been an interesting ride for us.
Great. Ron?
I'm in a 15-member cardiology group in Southern California between UCLA and Cedars, and we implemented a homegrown web-based electronic medical record in the mid-90s when we felt that we had reliable internet access at that time. And we have found it, because it's our homegrown version, that many of the things that we've heard about the difficulties of implementation, difficulties expense, inability to customize, we've been able to get around many of those features. Being a web-based product, we were able to immediately make changes, and we were able to customize that product to our work experience with an emphasis on ease of use and doctor use. And now we're entering a new phase where, in order to meet government requirements of discrete data, and to capture the important meaningful use items and report them, we've undertaken a mission to upgrade our system to meet the standardization and meaningful use requirements that are going to be broad-based and implemented and enforced with reductions in reimbursement if you don't comply. So the train has left the station, and it's an excellent time to get involved.
Great. Vincent, what's your experience?
We have had a similar opportunity as Ron. We took a base system, Med Informatics group out of California that is actually the sort of the guts underneath the GEMS product that's out there today. And we had, fortunately, one of our EP guys was very into the whole world of electronic records. And our system had a do not resuscitate sign on it. And so we were stuck, and we were having to change, and we're going to change our practice management system. And at the time, we realized that let's go all the way and begin electronic records. And so that was the 1997, and here we are now, well over a decade later, and have been able to migrate it into a world where we're 50 physicians in our practice in 17 locations in the suburbs of Chicago, working out at 8 different hospitals. So we have had a very geographically challenged approach to this product, but we've been able to integrate it well. We have, a very organized network today where we're able to move information across the practice and at the same time be able to move images and connect our world. It's helped us a lot, and we can talk a little bit later about on the quality side, because I think it's helped us do a better job at tracking where we were and where we got to today.
Okay. In my experience is I'm in a large multi-specialty group, the only one of this panel in a multi-specialty group, and we have bought a product 5 years ago from GE, previously called Logician, now called Centricity, and have had a struggle in our time to make it a product that suits both our primary care physicians of our group, but also the different specialists, the gastroenterologists, the nephrologists, the cardiologists. So of the panel, we have a good mix. We have 2 that have a homegrown cardiology product for single specialty cardiology, and 2 with an off-the-shelf solution. Right. Let's talk a little bit about what should we tell our audience about how they might go about now getting on board if they have not yet begun. What strategies that you might suggest? I think that I'm guessing that both Vincent and Ron would agree that at this point, growing your own is not an option. What strategy might you suggest to take on this if you haven't yet begun?
Well, I would say that if you listen to Ron, I think he had the positives of their system are out there in off-the-shelf systems today. And as I had alluded to before, we had gone with an electronic medical record in the very early 2001, which and we did it for all the right reasons. We knew what our goals were, and the only problem is we had really no good experience on how to choose. And we chose badly. We chose based on, I think the deciding factor was that we were so in love with our patient management system, our billing collection, that we went with a company that did our patient management system because we thought that would make it seamless for us. And in fact, it did not. And in fact, it was rigid. And in fact, it changed our workflow. And in fact, it changed it so badly that I could not get more than 3 of our physicians to adopt that electronic medical record after we had spent the better part of $500,000 to install it. So the good news for us is we were not a democracy, but we were a benevolent dictatorship. So I was able to get our guys to switch. And we switched to a web-based system, very similar to what Ron was able to develop themselves. And it's a web-based system that is very modifiable, and it was modifiable in very short order. So that we were able to, instead of adjust our workflow to the electronic medical record, the medical record was modifiable to our workflow. Every electronic medical record is going to change your workflow. The one that changes your workflow the least, but keeps you productive and organizes and efficiently organizes what you need to do, is probably the better. So our second system was great, and we only changed because of integration. So if I was going out and starting over at this point, I would look for a web-based system. I would probably, in today's world, since nobody really knows whether you're going to be able to stay in private practice or become integrated in the next 5 years, or what the ACOs or any of the aspects of health reform is going to create for us, that I would not make a huge upfront investment except for the hardware. And I would go out and look at some of these web-based systems that you can do on a monthly basis, so your upfront costs are not huge.
Okay.
Yeah, I think starting over today would would be a lot better. You wouldn't have all the arrows on your back as a pioneer. I think I would start by calling your regional ONC office. The ONC for Meaningful Use and Certification has set up regional offices that are going to be a resource. So I would first look at resources. The second part would be there are some proprietary databases where you can put in your needs on the web. Several, and the American Medical Association has some, and local resources. The third, which is an attractive option if you're using a dominant hospital, is to go to your hospital vendor in a spoke and hub scenario. There's a stark exclusion that allows hospitals to distribute electronic medical records at a substantial discount without that being considered a kickback. So that can be as little as 15% of the hospital's cost to do that. And that certainly will get you along the way of a reduction in cost. And then finally, the issue of workflow and your patient management system is very important. I think it's if you're not connected to a hospital, you really have to begin to look at an integrated solution that will both satisfy the business needs as well as the doctor needs. So there'll be compromises in getting that together. So I think architecture, infrastructure are good starts. And as he mentioned as well, I think the first step is to build that infrastructure and decide what clients you want in your room, build the infrastructure in the office, and that's really and the infrastructure cost, personnel, and work are the major cost. Usually the licensing and the software can be secondary. Hopefully you will not make a change going forward because the products are substantially more sophisticated than they were 10 years ago.
Right.
So in terms of things that I think I'm hearing you say that all of you adopted an EMR early, and you did it for what you thought was good patient and clinical and practice management reasons. Now, would you think it's fair to say that many of those reasons may still be in line with why a physician might choose, but the bigger reason why is that there's going to be mandates, there's going to be requirements because of decrements in Medicare reimbursement, and that there may be other forces out there, such as joining an ACO. There may be other payers requiring physicians be on electronic medical records. Some people have even alleged that there might be part of credentialing or recertification for board certification. Do you think that these are all legitimate reasons that those physicians who aren't yet on electronic medical records might really need to think about it?
I would just add one corollary to all that. I think it's a big piece of this is about having internal leadership in your organization. This can't be something you delegate to your staff or to someone else. There has to be a champion who not only buys in as a physician and gets involved and goes to site visits and looks at other sites, but then has to come back and convince his partners. He's got to come back and say, here's the reasons that the world is changing. We're going to be reimbursed this way. It's going to be mandatory. You know, at least the guys in my group, it takes a while for them to change, to adjust. And so, we needed someone who was a real driver who said, guys, here it is. Let's begin small. We'll begin with a pilot. We'll work our way forward. But that, was, at least for us, very helpful to have someone who is driving it on the physician side.
Not only do you need a leader, but that leader has to be a psychologist also, because the adoption of electronic medical records, and especially the interaction of electronic medical records with a physician, sometimes can require psychiatric intervention. It's a difficult prospect to go through, and it can be difficult. But I think you're right about that. You definitely need a leader, and certainly the carrot and the stick that government has created for us now with some upfront reimbursement for adopting EMR, but penalties for not doing meaningful use in the future, I think is an impetus that people have used to get into the arena. But in the end, it's really about coordinating care, good decision support software, the ability of an electronic medical record to remind, it doesn't educate. Decision support software, for instance, doesn't educate us, but it reminds us that we need to make sure patients are on aspirin, they're on ACE inhibitors, they're on beta blockers when they should be, they're on a statin. So there's some very positive things about electronic medical records that improve quality in the long run, I think.
I think that's the bottom line. I mean, if you're looking for reimbursement from the government, or you're looking to reduce your cost, or you're looking to improve your business function, those are probably things that can happen. But the real fundamental issue is quality of care. And when we compare, and of course we're going to metric this going forward with proper scientific studies, and there'll be some doubters who will confuse and say, well, there's no proof and it's going to harm care. But on a personal experience, having done this for 10 years, it's almost inconceivable to me to be in front of a patient and not have the cath, the echo, to be able to chart the lab, to know the allergies, to have a fundamental problem list, to go into your e-prescribing solution and know every drug prescribed by every single doctor. It is obviously better care. I feel a better physician for being able to make a decision based on all the information that is immediately available, instead of thumbing through things, relying on filing. So I think everything that you talked about in terms of disincentives, incentives, meaningful use, I think the proper attitude to go in is with the hopes, and I think probably all three of us have achieved that, of better patient care. That's really what electronic medical records is. And we are criticized as an industry for not appreciating that. Airline industry, banking industry are light years ahead of what we do. And so the time has come. Now the disincentives and incentives are modalities to get better patient care. We hope to metric that going forward.
I guess the one thing, though, I would want to make sure that we share with our audience, because there are many enthusiasts, both in the government and in payers, who see the benefits of the electronic medical record. But for those physicians who haven't yet adopted, there's a certain amount of hesitancy, cost, change in the way they practice. And I think that all of us, and I'm the most recent adopter, only 5 years on electronic medical record, I certainly see the benefits, Ron, that you've outlined. I think that they're clear. You didn't even mention accessibility from anywhere, from my home, from multiple hospitals, the portability, be able to provide patients with data and medication lists at an instant, all wonderful benefits. But I think by not acknowledging the cost to the physician, and I don't mean just financial cost, but that huge amount of pain that it takes to go from a paper record to the electronic medical record, between 1 and 2 years, can be very, very difficult. And I think it's really important. I think that as a cardiology profession, for those of us who have adopted, it would be better if we were honest and disclose that to our colleagues who haven't yet adopted. Say, oh no, this is all going to be just great quality, not that much cost. I think we actually do a disservice, because when you're in it and you're staying up until midnight trying to transition to the medical record, it's very difficult. Any objection to that?
I think we're absolutely all together on that, because we're sort of in a quick gratification specialty. Find an AMI, open the artery, send them out of the hospital in 48 hours. I mean, that's the world we're in, and guys are not used to this thing, which is a multi-year process. It took us 4 or 5 years to get everybody on board and there. And today, no one would go back to a man, period. They're all absolutely sold, but there was definitely a process from where we began to where we are today.
Well, I'm an electronic medical record masochist, because having done this thing 3 times is cruel and inhuman punishment. I think you can't minimize the fact that it does disrupt you, and it's financially unnerving, or can be, and especially when we have enough trouble trying to budget our offices and overhead. So certainly getting into the arena of electronic medical records from a financial standpoint is a huge undertaking. To have the organization in your office, whether you're a 1-man or a 2-man cardiology group, or you're a 15, 20 or greater size cardiology group, it takes some organization. It takes a physician leader, as you said, but it also takes leaders in nursing and at the front desk, and people that will interact with those electronic medical records. So it takes enormous organization to implement the medical record. And last but not least is the choice of it. I mean, it's a very, very daunting task to choose these and to get them up and running. They will disrupt your productivity. They will disrupt your workflow, at least initially. They may make you either more efficient or at least neutral in at some point down the road. But I doubt that they will make you more organized, more efficient, see more patients, and more productive in the end. But you should strive to get back to where you were before, but it does take time.
And one of the most important features, I think, to mitigate the difficulties of starting is to set your expectations at a level where you start slow. You really want to start with immediate gratification that comes back to the doc immediately. And some of those things that provide immediate gratification are a proper problem list. You can just start with a proper problem list. You're not going to get the entire note in on one encounter, but that problem list is your working area. Having the medications properly done so you can save with one click e-prescribing is another secondary issue. Having a previous past medical history. So you really, all of us have gone through this, and none of us would envision jumping into the kind of efficiency you have. You have to be patient, plan it out slowly, make a transition, have support do the transition, to reach where we, the three of us, are combined. And there will be some dead ends, there will be some disappointments, and there will be some kicking and screaming, and I remember
lots of kicking and
but
screaming.
In general, I would say we're more efficient today.
Yeah, we are.
Than we were.
We have some doctors who do twice as much work as other doctors and complete their notes because of electronic records. When we brought e-prescribing on, I had one doctor tell us that I was crazy. I was going to destroy the practice. And we implemented e-prescribing in 3 weeks across the enterprise with 90% compliance. But it's having some psychiatric support from the champion is very helpful.
Yeah, actually, our guy was talking about how he had a target on his back.
Right.
Everybody started to hate him, and I was like, no, it's not that bad,
Yeah.
You just
But,
stay the course.
I would tell you though that I believe you're more the exception than the rule as far as efficiency with electronic medical records. I think it takes a lot of years of working with a medical record to get to a point where you're as efficient as you were without them. I think that you can get to the point of doing that. I think that though, if I was going into electronic medical records today, it's an even more daunting task. You really have to, in part, have a crystal ball and know what your practice is going to be 5 years from today. Whether you're going to make if you're going to make this investment, are you going to make this investment all in, or are you going to do it more minimally invasive in a more minimally invasive way, where you're bringing in certain modules of it. Going into it today is a little different than when we went into it. And I really believe that the smaller practices today that are looking at this need to look at it in such a way that they look towards the web-based, very modifiable types of nimble electronic medical records that are out there that can satisfy meaningful use and satisfy PQRI and satisfy e-prescribing. And as long as they're government certified, either through CCHIT or one of the other organizations that are out there that are certifiable for meaningful use, they should be looking at those types of systems, and there's a number of them out there.
And one of the terms I think as you start off you should be considering is this concept of point of care. You really want to be able to consider the choice of your application to be something that you're going to be comfortable using in the front of a patient, and that is a definite skill set. You don't want your patient to think that they're spending more time on the computer than with you. So this requires, it's like when you were a medical student where you had paper and you're writing everything down for your senior attending and you're missing the whole patient encounter. You have to develop the skill set to be able to look at the patient, to deal with the fact that there's now a three-way interchange in the office, the computer, you, and the patient. What we've done, which has been helpful, is let the patient see what you're doing. In other words, in this triangular mode, when the patient sees the record and becomes part of the record keeping, and it's actually quite interesting. No, my father was 84, not 86, and didn't have a stroke. He actually had a CVA. Oh, okay. So that the patient becomes part of the process if it's done right and the room is set up right.
Okay, so let me just handle one last potential concern that the naysayers might bring up, and that's the issue of privacy and the issues of ability to operate with an EMR on the internet for patient concerns, and some doctors have this concern. How do we handle that for our audience? Is that something that we really